So my name's Kyle. I'm a nurse with Lutheran Senior Services Private Duty, and also our private duty liaison. So what I do is I help get people started with private duty assistance. And what private duty is somebody to come into your home and assist you with things, maybe if you're sick or you maybe hurt your arm or something like that, and you can't maybe put your pants on right very well. They'll come in and help you do that. Changing your bed linens, helping you, just being somebody there while you take a shower if you're afraid of falling. Those types of things. So we have our a la carte program here, which I'm sure most of all of you know about our a la carte program. So short visits throughout the day, Monday through Friday, 8 to 4:30. So the reason why I'm here today is to kind of answer any questions and go over diabetic health and what diabetes is. Okay, I don't know, and I'm not going to ask you if you're diabetic, but how many of you know what diabetes is? Okay. So maybe you've been diagnosed with diabetes, or you have somebody, or you know somebody in the family that's had diabetes. A lot of times, we end up at the doctor's office or the hospital, and they test us, our blood work, and they go, oh, well, you're diabetic, okay? Say you fall at home and you fracture your hip, heaven forbid, okay? And you end up at the hospital, and they do all the things that they have to do, the surgery, and they send you to the floor, upstairs to recover, and they've checked your blood sugar, and they've noticed that your blood sugar may have been a little bit high. Well, we want our blood sugar, when we're healing, very, very narrow, because one of the things that diabetes can do is slow down healing, okay? So we want these narrow margins of where our blood sugars should be, and that blood sugar means, whenever you eat something or take something in, our body runs on sugars. Okay, and our cells need those sugars in order to convert it to ATP or energy. Okay, if the cell is not, and we'll talk about this later, but if the cell is not able to get sugar, you start using our proteins for energy. Okay, so our bodies run on sugar. Our brain, our nerves, our tissues, everything runs on sugar. One way that you can get sugars is by opening a package of sugar and pouring it in your mouth or eating a candy bar, okay? Those are simple sugars, right? Those things that taste really sweet. Our taste buds and our sugars, those simple sugars are absorbed in our mouth and absorbed very quickly, okay? So we have enzymes in our mouth that break that sugar down and send it to our blood supply. We have more complex sugars called carbohydrates or complex carbohydrates that take longer to break down, but those are eventually broken down into sugar and stored or used for energy, okay? So you've gone into the hospital and your blood sugar is a little bit high, and so now all of a sudden they're giving you insulin, right? Because they want to bring your blood sugar down to find a narrow margin to help support that healing process. So then you get done at the hospital and you go to rehab, and you're sitting in rehab and they're still giving you injections of insulin, right? And then you have to go home. And they didn't tell you, a lot of times they don't tell you what diabetes is. They don't tell you how to manage it. They don't tell you why you're on the insulin. It's all a very fast process, and they're worried about taking care of the immediate need, and they don't do a very good job explaining these things. Okay, somebody can be diabetic for a very long time and not really have a good understanding of what diabetes is. So then you go to rehab, you're still getting insulin, and then they're going to discharge you home, and so you go home, and now you have to try to manage all this. A lot of times you'll go see your primary care doctor, and they'll say, okay, stop. You don't have to take the insulin anymore. All right? Sometimes it's a true diabetes. So they're going to test your A1C, and they're going to find out and say, yeah, you're diabetic. You need to continue taking this insulin. So a few of the ways that, so we talked about this, what is diabetes? Symptoms. So symptoms of diabetes, how do you know that you have diabetes? Can anybody answer that for me? How would you know if you had diabetes? What are some things, some signs that you think would be present if you had diabetes? Thirst? Yeah, very good. Okay. Anything else?
Could it be weight gain?
Some weight gain, possibly. Yeah.
Bathroom too often?
Bathroom a lot, right? What's another one? There's 3 specific things that we use. If our cells don't have enough sugar, what do you think our body's going to tell our brain?
We're hungry.
We're hungry, right? So we have increased hunger, increased thirst, and increased urination. Okay? And the reasons why is we said that our cells are not getting the energy that they need. Okay? So they're sending they're sending a signal to our brain that says, "Hey, we need energy. Let's eat." Okay? The other one would be thirst. So we've got all this sugar floating around in our bloodstream. Well, our kidneys detect that, and our kidneys say, "Hey, our blood's too thick. It's got too much sugar. We need to dilute it." So you're going to start drinking more, right? Well, our kidneys also say, "Hey, we've got too much sugar in our bloodstream. We need to get rid of it," right? So it wants to pee it out. Okay, so increased thirst, increased hunger, and increased urination. There's some other things, but those are usually the 3 main ones. So to touch more on what diabetes is, so we talked about sugars and where it comes from, and that our body needs sugars, but that doesn't make us diabetic. Okay, what makes us diabetic is our insulin. Okay, so our body has insulin in it, and the insulin is like a key, okay, that opens the door, right? If that key is broken, or you don't have enough keys to open the door, or you don't have any keys at all, okay, you can't open the doors to go through. So our sugar is too big to just flow in and out of the cell like sodium or potassium does, okay? So sugar has to be brought in by a key. On our cells, there's receptors. The receptors are specific to that insulin, okay? So when that insulin meets the cell wall, or it connects to the sugar, floats around, it meets the cell wall, that indicator or that receptor on that cell wall recognizes it, it opens up, okay, and it swallows that sugar, all right, or allows the sugar to come in to be used and converted into our energy, which is ATP, okay? So with diabetes, we have different forms of diabetes, okay? We have different problems with the insulin. I went too far. So it says there's 3 types of diabetes, really kind of 4 out of the ones, says 3 types. So type 1 diabetes, does anybody know what type 1 diabetes is without looking what? Go ahead.
Usually comes on with young.
Yeah, so usually you identify type 1 diabetes in childhood, and that's because the pancreas is not producing insulin, okay? It can't produce insulin, so there's something wrong with the pancreas, and usually it's due to some type of autoimmune disease or autoimmune function, okay? And it usually presents in childhood. So we also have, you may know somebody like that. I don't know when you were children, it's kind of like autism. Way back then we didn't see a whole lot of kids that had autism. Or ADHD, we started to discover that more later on. I don't know how many type 1 diabetics that you would have been around as a child. In our generation, it's not uncommon to see, a grown adult with, a pump that's on them all the time, and it's just something that they probably grew up with, okay? And they're used to. Usually with our type 2 diabetes, we don't see any type of insulin pump, okay? Unless there's something wrong with the pancreas, because it can usually generally be managed with just taking insulin throughout the day or some oral medications. So type 2 diabetes, okay, so the pancreas either makes less insulin than what's needed, or there's something wrong with the insulin or the receptors, okay? The key is bent, all right? So the insulin may be there, or the key may be there, it's just bent, and it's not connecting, it's not going in that lock to open that door, okay? Usually presents in adulthood. It could be due to weight gain, okay? Diet, different types of diseases, those sorts of things. A lot of times type 2 diabetes can be reversed or controlled with diet and exercise, the proper diet and exercise. A lot of times when we find out we have type 2 diabetes, it may be really difficult at that point to to get on that regiment, usually later on in life, to where you're just getting through it with oral medications and insulins. There's two other types of diabetes. The diabetes insipidus, okay, that's a problem with the kidneys. You're peeing too frequently, which is causing you to waste all of your sugar, all of your energy, which causes you to be diabetic. So it's really your kidneys are decreasing your glucose in your blood. Gestational diabetes, I'm sure, especially with all of you being female, you've heard of gestational diabetes before. Sometimes when a woman is pregnant, something happens within that period of time that causes them to be diabetic. Usually subsides after birth, but then the child and the mother are more likely to be diabetic later on down the road. Okay? All right. Any questions so far? Everybody getting it? We're good? Okay. All right. We talked about the increased thirst, the increased hunger. Some other things could be blurred vision, unexplained weight loss, or fatigue. Okay, so just feeling tired, sluggish. But who doesn't feel sluggish from a lot of different things that are going on in their life? So that's why we talked about those three key things, were the increase. Increased thirst, increased hunger, and increased urination. And slow healing with cuts and sores. So how many people know what kind of socks a diabetic is supposed to wear? Do you know? What color? White. The reason why they're supposed to wear white socks is because diabetes affects the nerves, causes neuropathy, causes them to lose feeling in their feet, okay? And a lot of times they'll step on something or injure their toe or their foot, and they won't know it. If they're wearing black socks, they take their socks off, they throw away, they don't know that they've injured their foot, right? And so that gets infected, and because diabetes slows our healing down, we end up with a huge infection. And then how many people know of somebody who's had an amputation due to a diabetic ulcer? Okay, yeah, so missing a leg or a limb because of that same thing. So it's very important with diabetics that we continuously monitor their feet and limbs for injury, and then when they do get injury, that we address it quickly, because we don't want them to go down that road. Okay. Why is insulin important? We talked about that. The ABCs of diabetes. So we get our A1C checked frequently. Okay, so the goal is to be between 5 and 6. Okay, our blood pressure. So diabetes can damage our blood vessels. Okay, it can damage our kidneys, our eyes. What happens is it plays havoc, that thick blood and all that sugar, it plays havoc on our kidneys, okay? Also, the thickness of the blood, everything plays havoc on the vessel walls, causing our blood pressure to increase, okay? Let's see, and cholesterol. So high cholesterol increases your risk of heart attack, strokes, so it can increase your cholesterol too, as well, because you've got all that sugar and carbohydrates floating around in your body. So treatment of diabetes, so we talked about diet and exercise is number one important, okay? So if we could get that exercise going and get the diet on the right track, then we're good. We have oral glycemics, okay? Those are things like metformin, glipizide. You guys have heard of those? Some of you may take them, okay? Those are our oral. Those help increase the production of insulin by the pancreas. Okay, so maybe if we don't have enough insulin, it'll help trick our body into increasing that. So how the body's supposed to work is whenever you take in sugars or food, you eat a candy bar, okay, that our body detects that we've eaten that sugar, okay, and it sends a message to our pancreas to create a lot of insulin at one time, okay? So if you have somebody that's diabetic and their blood sugar is way low, maybe 40s, 50s, whatever, okay, and they're about out, right? and they're hardly talking to you. You get them to eat some sugar, right? So let's spike their blood sugar up. Okay, you get them to eat a candy bar, their sugar shoots up. Their body produces a ton of insulin. Okay, because it's even though their blood sugar is low, our body's now detected that, and it's flooded with insulin, right, to try to get that energy out to the cells, right? Because something's wrong with our brain. Our brain needs energy, right? So after a little bit, what'll happen is if we don't give them something more or harder to break down that's going to sustain them longer, their blood sugar will crash, will drop way down because their body's been flooded with this insulin. Okay, so just giving them sugar or orange juice won't sustain them. They say milk, something with what we call our more complex carbohydrates, right? So we want to eat more complex carbohydrates. So it takes our body longer to break it down. So our insulin is at better use. We're not relying on our pancreas to produce so much insulin, and our body has time to break all that down and put it away where it needs to be. Is it going to, because you're diabetic, is it going to take care of all of it? No, you're still going to need some type of oral glycemic or insulin. Okay, so our insulin, there are different types of insulin that you can take. All right, there's so many different types of insulin. There's insulin that you take ever so many days. There's insulin that you take twice a day. There's insulin that you take 3 or 4 times a day. So we have our two main types are long-acting and our fast-acting insulin. Okay, they can be made from human insulin or synthetic insulin, like Novolog or Humalog. Lantus or Levemir. Lantus and Levemir are going to be your long-acting insulin. So what that means is I'm going to take a long-acting insulin in the morning, like Lantus, and it's going to work throughout the day, okay, to help me control my blood sugar throughout the day, right? So I still have to check my blood sugar probably throughout the day with meals. So we need something to get us through those meal times, all right? So I've got something that's getting me whether I'm eating or not, okay? And then I've got something that's going to get me through these meals. So I check my blood sugar in the morning. Maybe I'm on a sliding scale. Are you familiar with a sliding scale? Sliding scale is, a lot of times your doctor will prescribe you a sliding scale, and that means that you're going to check your blood sugar, and if it's over 150 or 120, you're going to take 2 units of fast-acting insulin. If it's between 180 and 210, you're going to take 4 units of fast-acting insulin. So you check your blood sugar before you eat, depending on where it's at. If it's 300, you may be taking 10 units. You're going to look at your sliding scale and you're going to decide what you need to take. You're either going to draw it up in a little tiny syringe or turn the dial on a pin, and you're going to give yourself that insulin. Okay? You'll do that for each meal, and probably some people do it at night before they go to bed as well. It just depends on where you're at as far as your diabetes goes. Okay. Types of insulin, we talked about that. I'm not going to go into too much detail about like NPH and glargine. I won't do that. There are some really cool continuous glucometers. Like this one. The one that I'm most familiar with is called a Libra, L-I-B-R-A. A Libra is a device just like that it's a disc, and the applicator is like it would be like a cap to a laundry detergent, okay? It's a cap. And it's got the sensor in it, and you press it up, and you clean your arm with alcohol, press it up against your arm, and then you push, and it pushes that disc onto you. There's a little needle in the middle of that disc and some wires connected to that. The applicator comes out along with the needle, and the wires stay in. There's some tape, like paper tape, that's around this, attached to that disc, that tapes it to your skin. Those usually are changed every 14 days. Okay. You have this monitor right here that will help you monitor it throughout the night, throughout the day. If your doctor wants to know what your blood sugar is doing at night, some people skyrocket at night, plummet in the morning. Some people plummet at night, and so there's just different types to each their own. But it'll monitor that continuously for you. Now, if it's lunchtime, you don't have to stick your finger. You just hold the monitor up to your disc, and it'll tell you what your blood sugar is. Okay. Really, really cool devices. Insurance is starting to pay for those. They're not cheap, or they weren't cheap. I don't know what they're like now. Okay, so a diabetic diet. Veggies, fruits, grains. Again, we talked about, so we have non-starchy and starchy, but we talked about staying away from more simple sugars that are easier to break down. We want to go for more complex carbohydrates. We don't want to do a whole lot of pastas because there's just a whole lot of carbohydrates in it. Okay, so we want to be mindful of how much carbohydrates that we're taking in. There, in the healthcare field, over the years, there have been different terms for a diabetic diet. We call it controlled carbs, consistent carbs, no carbs. So when you go to the hospital and you're diabetic, or a care center or something, that you'll have some type of diet restriction. If you're at that point, if you're at a care center, more hospital and rehab, they really like to control that. But if you have any loved ones that are diabetic, maybe a husband or whatever, and they're in a care center, a lot of times at that point, we try to encourage them to eat healthier, but we're like, as long as they're eating, we don't care, we'll give them insulin, okay? All right. Let's see. Proteins. I mean, you gotta have your proteins. Eggs are the perfect protein. I don't know if you like eggs, don't like eggs, but nuts, peanuts, dried berries. So non-fat, low-fat. So pretty much the same thing that you're going to eat on a, but you just want to be cautious about those carbohydrates. Okay. Long-term side effects of diabetes. So chronic high blood pressure, damage to the kidneys. Okay. Kidney failure. 75% of diabetics have at least one additional comorbidity. 45 have at least 2 comorbidities. And do you know what comorbidities means? It just means other disease processes, okay? Such as CHF or something like that, okay? Lymphedema. Wound treatment, something minor can turn into be something really big. Those are long-term effects. A lot of people that have diabetes, so up to 50% of patients who have lost their lower limb due to diabetes lose the other in 3 to 5 years. But a lot of diabetics have, at some point in their life, end up with some type of diabetic ulcer. I say a lot, not all, but a lot. Do you guys have any questions about diabetes? Yes, ma'am.
When you have gestational diabetes, are you more prone to get diabetes later on in your life?
Yes, I think it's a 20% increase in your chances of getting diabetes later on in life. But yes, you are more prone to getting it later on in life through gestational diabetes, and the child as well. So, I'm trying to think if I missed anything.
Big crowd.
Yeah? You guys have any other questions? You feel like you understand what diabetes is? How it affects you? Yeah? So if you ever do end up in that situation, you do go to the hospital, and you're like, why are you sticking me with this? You kind of have an idea. If you do end up in the hospital and they are giving you insulin or they are giving you oral glycemics, make sure that they educate you on how to use it before you go home. I see way too often people go to rehab facilities and they end up going home, they discharge them to home, and they have no idea how to give themselves their insulin or check their blood sugar. Okay, that's something that they can be practicing with you while you're there. So ask about it. Yeah.
Why is that?
Why is that? I think it's gotten very fast-paced and oriented, and a lot of the education, we're focused on, I think insurance is a big driver to that. We're focused on getting you better and getting you out, right? And we're focused on your your physical therapy, your occupational therapy, and your speech therapy, and the nurses are running around trying to make sure that this person's not falling and that this person has her meds, and they got to chart all of this, they got to do this paperwork. A lot of times they miss that opportunity to educate their clients. I see it with G-tubes, I see it with diabetics, and ostomies, colostomy bags. So, when you do go in, if you do go into a rehab facility, make sure that to ask the staff there that you're educated on this new thing in your life. Okay, so that you're going home, and you'll get home health, and home health will continue that education there with you. But make sure it starts at rehab. Okay. All right. Yes, ma'am.
I have an A1C of 7.1.
Uh-huh.
My doctor has not put me on any medication.
Okay.
Am I risky use of blue harming my kidneys because of that?
I think that would be a question to ask your doctor. So she asks, her A1C is 7 point something, and her doctor hasn't done anything about it yet. Is she at risk for kidney damage at this point? I would say ask him. If he is not concerned about it at this point, but you are, I would bring it up. I don't know what your relationship is with your doctor, but I would bring that up to them, and he may say, you're pretty close to 5 and 6, so you're okay right now. If you go any higher, like 8.5 or whatever, then we'll do something about it. Okay, he may say that. I mean, your kidney function is probably still good right now, or he would make some adjustments there. But I would say that's probably his thought process. But bring it up to him. Some doctors, there's a lot going on, and there's a lot that they're trying to fix with you and deal with you, and sometimes things get overlooked, but I would ask them. Okay?
Well, his reason was that he didn't want to put me on any medication because it would mess up other things in my body.
Good, okay. So, yeah. So evidently he's not too worried about the kidney situation at this point, right? And good, he doesn't want to put that on you, having to give yourself medication and giving you medication that might have side effects later on down the road. So, yeah. Any other questions? Yes, sir.
Has Ozempic been around long enough that they know that it's a very valuable tool to lower your A1C? I mean, is it?
Yeah, I don't know how long they've been experimenting with Ozempic. Just the last few years I've really heard about it. Maybe 3 or 4 years. So Ozempic is being sold on the black market because it works so well as a weight loss program, right? So they found out that the diabetics that they were giving Ozempic with were like just dropping weight. Everybody found out, and now they're like, it's an easy way to lose weight. Are there some risks to it? I would imagine so. Okay. But people are doing it, and I think right now we just don't have enough information. But yeah, I mean, it works for diabetics. I mean, it helps control their A1C. It's working well for them. Plus, they're losing the weight, which is also making them healthier in some aspects. But I don't think we know yet what it's going to do. At what cost? Later on down the road. It's expensive.
Advertisements on television now.
It's everywhere.
Yeah, it is everywhere. Yeah.
Uh-huh.
Yeah, I have a friend that I play soccer with that was taking Ozempic, and he lost a lot of weight. He's diabetic, but he was losing a lot of weight on it. So.
Yeah, I've been on it for about 8 months, and I've dropped about 50 pounds. And but I'm always worried that 5 years down the road, are they going to discover that, well, you're going to have kidney issues or something? But
yeah, you don't.
You just
don't
have
know.
your fingers
yeah.
crossed.
I mean, of course they've done studies where they think it's safe enough. I think it would be like any medication, newer medication that would, any medication. You look at 10 years ago, when say a medication came out 10 years ago, 20 years ago, it would have been that same process of, they're going to be, what kind of side effects are we going to have of this? And here we are today, and there's probably not a whole lot of side effects. And so, they've done enough studies, I think, where they kind of have a good grasp, but they don't know it all. They don't know everything. There's medications that they've had to pull off the shelves because, they did have bad side effects. They found out later on. So,
Are you aware of the new Dexcom Stellos?
no.
It's an over-the-counter GCM.
Dexcom,
Stello.
Dexcom Stello.
STLO.
And I'll have to look
And
into it.
it's not for, it only records for 24 hours and then the data is lost. To me, it's avoid sticking your finger.
Yeah.
And it's over the
Yeah.
counter.
Yeah, and you know, you're as I've had clients that or patients that come out of rehab or come out of the hospital. They go to rehab and they were given them insulin in rehab, or they were diabetic before. We got their diabetes under control. Now they're back at rehab or they're at rehab, and you know, we're checking their blood sugar every day, and it's 90 or 110, and say their sliding scale is 120. They want them to take insulin at 120 or over, and it's at 110. You know, a couple of weeks or a week of just a steady 110. You know, a lot of times we'll just get rid of that insulin, that sliding scale. They won't be on insulin anymore. Now, they may go home and diet may change, things may change, and they may be back on the insulin, or they may not. So as we get older, you know, there's things that happen in our lives that can cause this diabetes to appear, and there's things that happen in our lives with aging and things like that that cause it to kind of fix itself. So, what was it called?
Dexcom, Stello, STELO.
Is it a,
It's only been out since I think August. And I have them on.
it goes on your finger?
No.
Oh,
You gotta dig deeper than that.
Dexcom Stello, STELO?
Yeah.
Oh, a Lilly product, dedicated diabetes.
But it works like I have the app.
Yeah, the what?
I have the Libra.
The Libra?
Two.
Yeah.
And it doesn't work.
So how does, oh yeah, there's a disc. Yeah,
Yeah.
yeah, so there's an
It's
applicator,
basically the same, but
and then the disc, yeah.
over the counter for about $100. a
Oh,
month.
cheaper, yeah, less, yeah,
About the price of strips.
yeah. Huh. And how many days does the disc last?
2 weeks.
2 weeks, so 14 days? Okay. Yeah, so I mean, they're making, they're making progress with those devices. Yeah, I mean, sticking somebody's finger 4 times a day as a nurse is terrible. I didn't like doing it, you know? And you get some people, their fingers are so calloused, or they have low blood flow to their fingers, and, you know, you may end up having to stick them twice or 3 times, so, yeah. And then I've stuck myself, and then it's sore for a little while, you know? Or they're on Coumadin, and they're bleeding, their fingers are all bruised up, they're on blood thinners, yeah. All right, well, if you guys don't have any more questions, thanks for having me. I appreciate it. Hope you guys did learn something. And I'm always usually around, in and out of here. If you guys see me or whatever, you have any other questions about anything health related, feel free to ask me. We do run our blood pressure clinics here on
Second Wednesday. Down in the fitness room. It's on your calendars.
it's the second Tuesday. Wednesday. Okay, Laclede Grove's the second Tuesday. This is second Wednesday of the month. You guys can come get your blood pressures taken. Not only will I check your blood pressure, if there's anything wrong with your blood pressure, I'll also go over your medications with you, call your doctor, and figure out what your doctor wants to do, if he wants you to change medicines or whatever, or if he needs you to go to the hospital, okay? We've had, usually every blood pressure clinic that we have, I'm usually having to call a physician. So I think it's good. I talked to, if you guys are taking your blood pressure at home and you're on blood pressure medicine or you're worried about blood pressure medicine, try to take your blood pressure throughout the day. Don't just take it every morning when you wake up. If you take it in the morning when you wake up, if you've had your medicine, maybe it's 30 minutes after you took your medicine, your blood pressure meds haven't been able to work yet, okay? I'd say an hour after you take your medication, go ahead and take your blood pressure. But check it at night, because a lot of times people, their blood pressures are like 110. They've taken their metoprolol, or their lisinopril, and it's 110 in the morning after they take it, and they come to me at the blood pressure clinic and it's 175. Okay, and they're like, well, that's not right. My blood pressure is never 175. Well, it probably is. You're just not checking it at the times that it is 175. Okay, and I'm exaggerating, but yeah, try to check it at least twice a day, once in the morning and then once maybe with dinner. Kind of see what your blood pressure is doing. It gives your doctor a better idea on how to treat you. In a care center or a rehab or a hospital, we check your blood pressures, we check your vitals every shift, so 3 times a day, right? So it'd be in the morning, once around 3 o'clock, so mid-afternoon, and then once probably around 7 o'clock at night, okay? So the doctors have a better picture of what your blood pressure is doing and how to treat you, okay? Good, all right. Thanks, guys.
Thank you, Kyle.
You're welcome. Hope I didn't bore you.